So adult-acquired flatfoot. Okay, so we'll talk about kind of what the problem is, how patients present and how you work it up. And then we're going to describe some of the treatment. And this is, a favorite of kind of the foot and ankle questions on OIT and boards. They definitely always ask about these. So this is a patient who has a pes planus deformity. So here on this x-ray, you can, or not, on this image, you can see that the arch is here flattened and there's this kind of big medial sided bulge. You have the patient stand and you're looking from the back and you see kind of this large bulge, which is sometimes can be the swollen posterior tib tendon. And sometimes it can just be actually the talar head because the deformity is so prominent. So the posterior tibial tendon is, again, as we talked about from the biomechanics, right? So we know that it crosses posterior to the ankle axis of rotation and crosses medial to the subtalar axis of rotation. So then it functions as a plantar flexor and inversion, and then it contributes in a supination of your foot. And it does insert right here on the plantar aspect of the navicular or navicular tuberosity. But in essence, I mean, it really has a really large or insertion kind of along the whole bottom of the midfoot. And it acts as a stabilizer, right, as we talked about for the arch. And so when the posterior tibial tendon does not work, you don't have that rigidity of your hind foot. And so the subtalar joint just kind of falls into eversion. And when it's everted, as we talked about, the transverse tarsal joints are pretty parallel. And so the foot is just not rigid. It's very kind of floppy and soft. So the posterior tib tendon, it fails most commonly at a location just distal to the medial malleolus and kind of in that area between the medial malleolus and the or insertion at the navicular tuberosity. And this is because there's an area of hypovascularity. And this is a reason why many of the tendons will fail at that location. A lot of these patients oftentimes will be patients who have had flat foot their entire lives, but never had any problems or symptoms until they're in their 50s or 60s, and now it's actually hurting. And then some of them will have some sort of inflammatory systemic process like RA or diabetes. And then there certainly can be some that have trauma, although really most patients that I see with flat foot, they don't really recall any specific trauma. And then most patients also never say, oh, I took steroids. So, these are kind of things that are kind of stated in the textbooks, but I have them here, but I definitely don't have a whole lot of patients telling me that they've taken a lot of steroids or have trauma to their posterior tib tendon. So the posterior tib tendon, as I said, is this dynamic stabilizer of the arch. So when that actually starts to fail, your static stabilizers are going to start working. And so that's the spring ligament, which is that calcaneonavicular ligament that we talked about, also plantar fascia and the talar navicular joint capsule. So these become really stretched, and as your tendon fails more, and then these are really the only things that's kind of giving you that stiff hind foot, these will all start to stretch out. And then as these sort of stretches out, your heel will go into a valgus position, which is here, and then your Achilles will actually start pulling laterally, and then that's going to be a deforming force. It's going to make the deformity even worse. So this is our first question. I cannot remember who answered the last question.
It was me, Ryan.
Okay.
So let's go with Charlie.
Great.
All right. So what region of the posterior tibial tendon has the poorest intrinsic blood supply, aka watershed area? At the tendon insertion site on the plantar foot, the tendon insertion site on the medial navicular, at the musculotendinous junction, between the navicular insertion site and the distal medial mal, and posterior to the medial mal within the retinacular sheath. I believe, like you said, it's between the navicular insertion site and the distal medial mal, so 4.
Perfect. Okay, so these patients usually present when they're late 40s, 50s, and 60s. A few of them can be bilateral, and the vast majority of them are women. Many of them are a little bit heavier. They oftentimes have, hypertension as a comorbidity, and most of them will really just report this like vague, slow, gradual onset of pain. And sometimes they'll say, yes, it's activity related. The more active, the more they're on their feet, the more pain they have. And it's only in the later stages where the pain on the medial foot actually goes away and they start to have lateral pain. And this is because as the tendon really starts to fail and it's being pulled and pulled, at some point the tendon will just give way. So sometimes I see patients who come and, we operate on them and the tendon is just ruptured. So of course, at that point, once it's ruptured, there is no pain, but then that means their deformity gets worse. And so as their deformity gets worse, they end up getting that subfibular impingement. So the calcaneus and the fibula will literally hit against each other and they cause the lateral pain. So in someone who has a flat foot deformity and they have lateral pain, that can tell you that they're usually at their later stages because something has already torn along their medial side, which is where the tendon is. Few of them come in with saying they have some sort of minor trauma. Oftentimes they will have some calf discomfort. And then again, a lot of these patients are people who have had a flattened arch their whole life. It's never bothered them, but when they're in 50s or 60s, it starts to be painful. So for the physical exam, you obviously want to make note of where they have swelling, where they have pain. Again, I mentioned the subfibular pain, which is on the lateral foot or lateral side of the ankle. You want to look at these patients from the back. So you have them standing, you're looking from the back, and you're really looking at obviously the alignment of their foot, right? So here, oops, hold on, let me laser pointer. Okay, so here this is straight, right? So this is the leg and the heel. So you can clearly see it's in a collinear, line. But on this side, you can see the leg is here, but the heel is over here. So there's a valgus deformity. And then this is called a too many toe sign, right? You don't see that toes over here, but you do see it over here. So that's important. And then you also want to have them do a single, or you can have them do a double. Oftentimes I start patients on a double heel rise. And what you're looking at is two things. You're looking at number one, can they actually get their heel off the ground? And then two, you're looking to see that you want to see some inversion, right? Because again, going back to our biomechanics talk, when the posterior tib tendon fires, it inverts the subtalar joint. So you want to see that. So a healthy posterior tib, you're going to be able to see that hindfoot inversion. This is a deformity that's in 3 different planes. So in the coronal plane, you're going to see that hindfoot valgus, which is this, right? You're looking at them from behind, you see that valgus. In the sagittal planes, you're looking at it from the side, you'll see that the midfoot just kind of collapses. That's the easiest thing. That's what patients also see, right? They're like, my foot, my arch is collapsed. I have a flattened arch. And then in the axial plane, where you're kind of like, looking down at your foot, you'll see that the forefoot will actually rotate outwards. So we call that forefoot varus. So it's a deformity in 3 different planes. It's really important to recognize that because surgical treatment will depend on correcting deformity in all 3 planes. It's important to get x-rays, weight bearing, of course, of the foot and ankle. And so you want to get an AP lateral immortus of the ankle, AP lateral oblique of the foot, and then hindfoot alignment views are also obtained. On the AP of the foot, we're looking at a couple of things. So here I've kind of drawn out where the navicular tuberosity is, and then this is the medial aspect of the talus. So you can see there's this portion of the talar head that's uncovered. So we're looking at the talar head uncoverage at this portion. And when we talk about classifications, 30% uncoverage or maybe 40% uncovered represents a clinically important cutoff in terms of surgical planning. On the lateral view, we're looking at Mary's angle. Mary's angle is simply the angle along the shaft of the talus and the shaft of the first metatarsal. In a normal, healthy ankle or foot, you'll see these lines kind of basically just being collinear. It's one single line, but in this patient who has posterior tib tendon dysfunction, you'll see that the talus is pointing plantarly into the ground, and then this line that's drawn along the first metatarsal shaft is pointing in this direction. So the apex of this line is actually plantar, right? So that tells you that the arch is essentially fallen. This is just another representation of Mary's angle. So again, normal is collinear. This is mild, where it's kind of apex planarly, maybe 15 degrees. And this is a more severe deformity where the talus is really pointing into the ground and apex planarly. And they're saying, here that it's 30 degrees. Hindfoot alignment views are here. And these are, I find, really helpful. So you can get them on both feet, and basically you just drop this plumb line down to the ground. That's along the shaft of the tibia, and then you draw another line along the shaft of the calcaneus, which would be right here. So this is pretty good. Whereas here you can see, like, here is your calcaneus, and then you're drawing this line, so you can see that it's kind of it's lateral to the plumb line of the tibia. So this is showing that there is hindfoot valgus. I'll just touch briefly on these CT scans. So CT scans are really helpful to kind of look at the joints, particularly the show part joints, which is the CC and the TN joint. But more importantly, recently, they've done these weight-bearing CT scans, and they're really helpful because you can see what the joints actually look like when the patient is actually weight-bearing. And this is I think a really important study that with these weight-bearing CT scans, they found that the patients who have Flatfoot actually have a different morphology of their subtalar facet. So the posterior facet, the subtalar, has this valgus orientation in patients who have posterior tib tendon dysfunction. And so they're more prone to actually having this problem happen. And then when it does happen, they're more likely to progress faster. And so these patients, if you are able to have access to these weight-bearing CTs, you can help to identify patients who might potentially need surgery earlier.
Dr. Chen, for the hindfoot alignment films, are you getting them routinely? What is obviously it's good to get them and compare side to side, but what does it add to you in terms of like operative decision making?
Yeah, great question. So here I haven't gotten them routinely, only because I have to go over to X-ray and show them how to do it, and I've just been lazy and maybe doing other things. But yes, I do get them. When I was in practice in Chicago, I got them routinely, every single one. What it adds is, so here I'm showing you just simply that, you drop these two lines and you say, oh, okay, it's in valgus, right? But there's another measurement that you can measure the distance from the center plumb line to where the center of the calcaneus is. And so later on, we'll talk about this medial calcaneal osteotomy, right? So if I'm saying, well, this measures, 2 centimeters, and then normal side for this patient measures 1 centimeter, it tells me, okay, I probably need to shift this heel about 1 centimeter. So that's where it's really helpful. I don't get them now when I do these Flatfoot cases, partially because I feel like I've been doing this for a while. So I know how much to shift the heel, but it is really helpful. I also like getting these because it shows the patients. So this is their initial pre-op X-ray. So I'll get them post-op, and you'll see the heel is over here, and patients really like that, right? They see, oh my gosh, look at how I was and look at how I am now. But good question. It does, when you measure the distance here, that actually does help you to determine how much of a shift you need to do for your calcaneal osteotomy.
Cool. Thank you.
Yep. So MRIs and posterior tib dysfunction are not routinely indicated. They certainly can be done, and sometimes I do get them, or sometimes I should say patients come in with them because they've been seen by someone else and they've already ordered them. So in that case, you definitely see that there is, some abnormality of the posterior tib tendon. And this is huge. Your posterior tib tendon is usually not that big. Oftentimes you can look at your spring ligament, your deltoid ligament. And then the other thing is you can use that to identify any bony marrow edema. So for instance, if they had that subfibular impingement on the outer side, you see marrow edema within the distal fibula and the calcaneus. So the classification is this, and this, I'm presenting this, and we're not talking about the new classification, which I presented in Grand Rounds, only because that new classification has just been published in October of 2020. I don't see a whole lot of articles out there who are using that new classification, although I do agree that it's better. So I think for testing purposes and for you guys, this is the classification that they want you to know about. So this is a classification that was developed by Johnson and Strom in the 80s, and Meyerson added it. But it's pretty simple. Basically, stage 1 is just someone who has tendinitis, right? They do not have any existing deformity. They just have tendinitis, they have pain. Stage 2 are patients who have a deformity. So you can see their arch is kind of falling, and but it's flexible. So you can reduce it and kind of get the foot into a neutral plantar grade position. Stage 3 is stiff. So they've had it for so long, you can't reduce it. And usually that means that there is some arthritis in their subtalar joint. And then Meyerson added stage 4, which is essentially that it's gone on for so long that not only is the hindfoot subtalar joint arthritic, the ankle joint is also arthritic. So now you get an x-ray of your ankle and you see the ankles tilting into valgus. And stage 2 I think is the most tested on, and is also, the most controversy. So a lot of the literature out there in foot and ankle really focus on stage 2. And also this is because stage 2 is a point where you can kind of get to patients and fix them and really make the most impact before they end up getting to stage 3 or 4. So when you have a patient who has stage 1, so these are just patients that have some tendinitis. I oftentimes will say, look, it's painful. Why don't you just go into the boot for about 2 weeks? It will probably get better. Other things are orthotics. So you can, have patients, get some off-the-shelf orthotics. You can also have patients get this device called a UCBL, right? And so, and this is what a UCBL is right here. So the difference between orthotics and UCBL is important to understand. And they do make distinction of this in the test, right? Because the orthotic and UCBL are not the same. Orthotics are just kind of, whatever, your Dr. Scholl's, or you get something made and it's just something that's on the bottom of your foot. A UCBL has these flanges that go up or all around the heel. So it's it's more supportive, and it really controls the hindfoot. So that's what a UCBL is. Certainly you could do AFOs, but in stage 1, no one's going to wear AFO, but you can certainly tell patients to use a lace-up ankle brace. Most patients will go for that. A lot of times I tell them to take some anti-inflammatories. And the idea in stage 1 is you just try to quiet the tendon down, because really all they have is tendinitis at this point. And then once the tendon is quieted, you start physical therapy. And I always stress doing Achilles and gastroc stretching as well, because that is ultimately going to be a deforming force if this condition progresses. So we want to really stress it or stretch it. And if patient's stage 1 really just does not get better and you have to do something, a synovectomy, a simple synovectomy is the answer. Okay, so that leads us to the first question, and I cannot remember who was the last one that answered it. So call on someone who has not. Oh, Charlie, right?
Yeah, I had asked, or I'd answered the last one, so I'll ask Marcus.
Great.
All right, so the UCBL lower extremity orthoses are thought to work by Supporting forefoot or midfoot and rigid deformities, controlling the hind foot and flexible, controlling the ankle when instability is present, or accommodating forefoot deformity. UCBLs. I think the focus is more on the hind foot for these.
That's correct.
And
So you can, you can roll out 1 and 2, 4, and 5.
It's not a forefoot thing either because I know what they look like. They sit right on the heel, and it doesn't have to do with ankle instability. So it must be 3, controlling the hind foot and flexible deformities.
That's correct. Exactly. Yep. Okay, Marcus, call on someone else.
Let me see. Who from my class hasn't gone yet? I'll call on Monica.
Okay.
All right. A 6-year-old woman has pain along the medial aspect of the ankle. Examination reveals pain along the posterior tibial tendon with a normal single toe raise. Despite undergoing conservative treatment consisting of NSAIDs, physical therapy, and cast immobilization for 8 weeks, she continues to have pain. What is the next appropriate step in management? So steroid injection, subtalar joint arthrodesis, synovectomy of the posterior tibial tendon, reconstruction of the posterior tibial tendon, or anterior tibial tendon transfer and calcaneal cuboid arthrodesis. I don't think that 1 is appropriate. 2 and 4 and 5 seem more than what she would need at this point. So I would do a synovectomy of the posterior tibial tendon.
Yep, exactly. Yeah. So I mean, she has a normal single toe raise, right? So that alone just tells you that person is stage 1. So you're not going to do anything crazy. So if you have to do something, just do a synovectomy. All right. Monica, pick someone else.
Oh, wow. So much power. Eric McDonald.
That's wonderful.
You're welcome.
Figures 1 and 2 are the weight-bearing radiographs of a 49-year-old woman who has had several months of increasing pain and deformity in her left foot. She points to her plantar medial arch as her greatest area of pain. However, she also has pain just distal to the tip of the distal fibula. Her pain worsens with walking or navigating stairs upon examination. She has a flexible unilateral pes planus with increased heel valgus and forefoot abduction. She's unable to perform a single heel raise. In addition to physical therapy, what is the best course of treatment at this time?
Let me show you the picture.
Erica's definitely PRP, so
that's right.
Okay, so she has, pes planus, forefoot abduction. So a steroid injection is not going to help. Platelet-rich plasma is never going to help. An ankle foot orthoses, I don't think is necessary. You could do, although the lateral post is going to worsen her foot. So I do think it's probably an ankle foot orthoses.
Yep, exactly. Yeah, so you definitely don't want, so we know PRP, steroid, not great. You don't want to put a lateral post, right? Because lateral post is going to kind of tilt her foot into more valgus. So that's making it worse. So, and then also for something like this is pretty severe. I mean, if you look here, remember how I said in the classification, you can measure how much the talar head is uncovered. This is more than 50%, right? Like here and here is a talar head. I mean, this is maybe 60%. So when it's, significant, an orthotic is really not going to do anything. So yes, you're going to offer this patient a AFO. All right, so moving on to operative treatment. So and this is in stage 2. That's where patients can usually have, are candidates for surgery. But what I find really difficult is when I see a patient comes in with stage 2, it is really hard to tell them you have a tendon problem, but hey, I'm going to do, a tendon transfer. I'm going to do bony stuff. And everyone's like, whoa, what are you talking about? So I usually start off with non-operative treatment in stage 2, but I do tell them and sort of plant the seed that this is progressive. And so we're going to do the non-operative treatment, but expect that there's a chance, a large chance that you may not actually get better from just conservative treatment and that you may end up needing surgery in the end. So surgery comes in 2 flavors. So there is the soft tissue procedures and there is the bony procedures. So start off with the soft tissue procedures, and this is what patients can understand and relate to as well, because you're telling them this is a posterior tendon problem, right? That the problem isn't, or the problem is the tendon isn't working. So what we have to do is try to help this tendon. And usually a simple repair, so it isn't going to work. And a lot of times the tendon is so stretched out, you can repair it, but it's not going to really improve their deformity. So in addition to a simple repair, you also have to do a tendon transfer. And the easiest tendon that you can transfer is the FDL, because it is literally the next tendon over. And then also for the soft tissue work, I always important to not forget about the gastroc and Achilles, because that's a major deforming factor as these deformities progress. So definitely want to tell patients, well, in addition to some of the soft tissue work, we're going to need to have to probably lengthen your gastroc or your Achilles tendon. All right, Eric, pick someone else.
One moment. I might have missed who's been called on already.
Let's see. I'm just gonna.
Maybe.
How about Tiffany? I'm just scrolling through names, and if I see a name that hasn't been
Tiffany,
called on.
she'll get it.
Hello.
Hi.
You are correct. I have not been called on. So figure 1 is the radiograph of a 46-year-old woman who has had several years of foot pain. She has demonstrated only minimal relief with boot immobilization, orthotic use, and PT. She elects for surgical correction of her deformity. In addition to osteotomies and an FDL transfer, which other soft tissue procedure may be necessary based on an intra-op exam?
So let me show you so there's her x-ray.
Okay. So
Right?
she does have a flat foot.
Yeah.
Well, based on test taking skills, we were just talking about gastroc / Achilles lengthening. So I'm going to go with that.
Oops. Yes, that is correct. Yes. I tried to make these easy for you guys, right? I say it and then I ask you the question. So just have to listen. All right, Tiffany, call on someone else. Next question.
Oh no. Okay, who has not been called on? Let's see.
How about Sergio?
Sounds excellent.
All right, chronic Flatfoot deformity is most commonly associated with the contracture of 1, plantar fascia, 2, spring ligament, 3, deltoid ligament, 4, intrinsic tendons, and 5, gastroc soleus complex. So you talked about releasing the gastroc, so I'm going to guess 5.
That is correct. All right. Okay. So moving on to talking a little bit more about surgery. So what are our goals in surgery? So first and foremost, you're really trying to relieve pain for these patients. You're definitely trying to do everything else, but it's really to relieve pain. In addition to that, you're trying to obviously restore a more stable and properly aligned foot. And if at all possible, we want to try to preserve all the joints and keep it a supple foot and try to help them restore power and foot control. So after you sort of debride the posterior tibial tendon, you want to do this tendon transfer, which is essentially taking the tendon next to it, which is the FDL, and you want to transfer it into the navicular. So you drill a hole from dorsal to plantar along the navicular body, and you can kind of tunnel the FDL tendon through the drill tunnel and sew it back on itself if you have enough of your stump in your harvest, or you can just use a interference screw, which is what I usually use. And it's also important to help patients understand why we have to do additional bony procedures and why this one simple tendon transfer isn't going to work. So I usually tell patients that if I show them this chart, I say, look, the posterior tibial tendon, the relative muscle strength is like 6, and then the FDL is only like 2. So we're taking a much smaller tendon with much less power, and it's not going to be enough to kind of function as your normal posterior tib. So because we're taking a smaller, weaker tendon, we do have to do some other work around your foot that is the bony work to kind of really help this continue to work in the future. So how do you know which bones you want to shift? And there's 3 different areas. And this goes back to understanding that the deformity is in 3 different planes. So the first problem is the heel valgus, and that's in that coronal plane. And the treatment of choice here, so if you see, so this patient here, she's got this valgus hindfoot, is the surgical treatment choice is this medial calcaneal osteotomy. So you're really kind of cutting, making a lateral incision in the heel, watching out for the sural nerve, and then you dissect down to the lateral border or the lateral cortex, the calcaneus, and you do a kind of a straight cut here, and then you shift the heel medially, and then you can use a screw or 2 to really hold that fixation. And usually these are good surgeries because they heal. You know, there's a huge surface area here of cancellous bone to cancellous bone that's in contact with each other. And patients, you know, heal from these usually with no problems. So if we look at some outcome data for patients who are stage 2A, so patients who have a deformity, but they're still flexible, these patients all had an FDL transfer and then had a medial calcaneal osteotomy for stage 2. And they followed them for 15 years, a really long-term outcome, although it's, you know, pretty small group. These patients do really well. I mean, they're happy with their outcome. They're able to get back to activities and really don't have a whole lot of pain. When you do these medial osteotomies, the standard is to really, or the agreement amongst, you know, most surgeons is you can shift them about 7 to 15 millimeters. I would say most people, you can easily shift them from maybe about 7 to 10 millimeters. I don't think I've ever shifted about 15, but they you know, have a really nice correction that you can visually see. Okay, so Sergio, so we're gonna call on someone else now. Here's our next question.
Let's see. Hunter?
Great.
All right, so an otherwise healthy 50-year-old woman has a painful planovalgus deformity of the foot that is the result of chronic posterior tibial tendon deficiency. Both the hindfoot and forefoot positions are passively correctable. Orthotic management has failed to provide relief. Treatment should now consist of 1, reconstruction of the posterior tibial tendon and spring ligament, 2, reconstruction of the posterior tibial tendon and medial displacement calc osteotomy, 3, varus osteotomy of the calc and reconstruction of the spring ligament, 4, triple arthrodesis and lengthening of the Achilles tendon, and 5, arthrodesis of the talonavicular and calcaneocuboid joints. Let's see, so we talked about that 1 doesn't work. 4 and 5 seem kind of extreme. And then, let's see, I guess I would probably go with 2.
Correct, yeah. So you don't wanna do a varus osteotomy, and yeah, and then also, you know, you don't wanna do a reconstruction, well, I don't know. Yeah, so varus osteotomy, maybe you can, right? Because you're trying to push the heel medially, but you don't want to really reconstruct the spring ligament, although it's certainly been described, but we know that doesn't really work. So yeah, so the answer is reconstruction of the posterior tib tendon, medial displacement osteotomy. Okay, so moving on to midfoot and the forefoot. So we've addressed what we would do for a heel valgus. So another deformity, now looking on the axial plane, you can see that patients often have this midfoot abduction, right? And so this is a deformity that occurs through the talar navicular joint right here. So in this diagram, the talar head is nicely covered. And over time, as the patient has this flat foot, their whole foot will kind of rotate laterally. And so you can see right here that the talar head is beginning to be uncovered. And when you see this, you can correct them with a lateral column lengthening. One thing I should say with lateral column lengthenings is that not everybody believes in this, meaning that you'll probably get tested on it because it's a well-described surgery with good outcomes, but in practice, not every surgeon will actually do these. When I started off, I really like them. I still do. I do them a lot, but I know lots of surgeons who don't do these at all. So this is not part of their procedure for a flat foot surgery. So that's something to keep in mind. So lateral column lengthening was initially described as this distraction arthrodesis here at the calcaneal cuboid joint. The problem is when you do that, it gives a very stiff lateral hind foot. And so patients were having stiffness and they were also having some pain over here. So this distraction arthrodesis has really essentially been abandoned. And so what we do now is a single cut straight osteotomy. And that's pretty standard of where you just kind of make a single cut in through the anterior process of the calcaneus. And then you're going to insert a piece of bone graft and that kind of lengthens that lateral column. And then you can imagine that's going to essentially rotate your whole foot from, kind of this abducted position. You're going to rotate it medially and it's going to cover your talar head. And that's how the reduction of this joint can occur. The problem with this procedure that I personally had is that a lot of times I've had some non-unions, and I've also had patients who had some delayed failure of these grafts. So there are an alternative, which is these step cut osteotomies. And this is what I usually do now. Take a little extra time because you have to cut the step here. But the idea is that you put your graft here on top, these vertical limbs. You make this cut and then you put your piece of graft here and you put a piece of graft here. And then you can lengthen it the length of this horizontal limb. But because there's good bleeding cancellous bone here and here that's in contact with each other, it does help with the healing process. So I've had good results with those. The problem with lateral column lengthening and the reason why some surgeons don't do these at all is that there is a high incidence of lateral foot overload and stiffness and pain. So Delanda HSS found almost half of the patients who had a lateral column lengthening had some level of foot pain. They weren't severe foot pain, but they were some discomfort on the lateral side. And the reason why this is the case is that there's really no consensus. Like, we don't know how much to really lengthen, and there's no set guidelines. And in 2015, they actually, same group, HSS, came up with this lateral incongruency angle, and where you measure kind of this angle alpha here, and it really helps you determine how much you can lengthen your lateral column. They essentially said that you could get a correction of 7 degrees for each millimeter of lateral column lengthening. And this was actually as part of the maintenance certification articles that we had last year. So I wouldn't be surprised if, maybe they would start asking about this for you guys as well. So this is just a patient of mine that I did a lateral column lengthening on. And you can see in these preoperative x-rays that, this patient had some talar head uncoverage here. And then you can see there's a little bit of sag at the talar navicular joint. And then after they had this lateral column, and of course the calcaneal osteotomy, that this sag is improved. And then also on the AP view, their foot is not as abducted anymore. So for lateral column lengthening, this is just the consensus statement that that came out from last fall when all these experts in Flatfoot kind of got together, and they are recommending that you do this lateral column when the talar head is uncovered greater than 40%. And then if you end up seeing some adductions of the talar navicular joint, that would mean that you've over reduced it. You've done a little too much. So you want to kind of take out your graft and under reduce it a little bit, because that's going to lead to higher lateral foot overload. And then usually about 5 to 10 millimeters is sort of an adequate lengthening to achieve the correction. And I would say when I do it, it's anywhere between like 6 or 7 millimeters of lengthening to kind of get a nice correction. Okay, I don't remember who did the last question. Oh, I think it was Hunter. So Hunter, why don't you pick someone to do this question?
All right. I think Syed, have you gone yet?
I've not.
Awesome.
So the question is, what joint sparing procedure most effectively corrects midfoot abduction associated with flatfoot deformity? The options are medial cuneiform osteotomy, lateral column lengthening, FDL transfer, medial displacement, calcaneal osteotomy. So I think we can rule out 1 and 3, and then the calcaneal osteotomy was more for the hind foot. So I think it's the lateral column lengthening.
Perfect. All right. So now moving on to the last deformity, right? And that's the first ray. And this is where, you know, when you're looking at the patient on the sagittal view, you can see that the arch has fallen. So it's really important after you correct the hind foot and you do the lateral column lengthening, you want to look at the first ray. That's usually the last thing that you correct. And the first ray, oftentimes in a long-standing patient with long-standing pes planus, the first ray is going to be elevated. And so when you see this, you really want to kind of bring that first ray down, because you essentially want to restore the tripod of the foot, and the tripod of the foot being the calcaneal tuberosity, the 5th metatarsal, and the 1st metatarsal, because you want that 1st metatarsal head to kind of come down. And this is really important because it not only does it restore the weight-bearing tripod of the foot, but it also prevents further collapse, of that medial column. Oftentimes, the surgery of choice is to do this cotton osteotomy, which is an osteotomy through the medial cuneiform. So you open it up here, and then you essentially put a dorsally based wedge, and then that's really going to kind of bring that first ray down. When a patient has some evidence of arthritis, the first TMT, instead of doing this osteotomy, you can just do a fusion. And when you're fusing it, you can just slightly planarly translate the 1st metatarsal, and then you'll get the same effect. And a lot of times with these patients who have these long-standing flat-foot deformities and putting lots of pressure in the first ray, these patients oftentimes have a bunion. So sometimes when you do these patients, I'll say, well, can you correct the bunion at the same time? And you usually do, because the bunion is a result of their deformity. So stabilizing the first ray is very important. And when you decide, whether or not you need to do this medial column correction, the indication or the way to figure this out is actually clinical. So it's not based on an x-ray. So when I consent patients for this procedure, I don't say I'm going to do it, I say possible. And so that what they mean is that, after you correct the hind foot and the lateral column, you're going to look at the foot, right? So if you're looking at this foot, this line that I've drawn, you can see that the first ray is elevated. And then here is sort of what it should normally look like. The first ray and the rest of the foot should kind of be equal. So the first ray is elevated, then you do know that that tells you that you have to do this plantar flexion osteotomy. That was stage 2. So now we're moving on to stage 3. This is a patient who has kind of let it go, and now they actually have arthritis, right? You cannot reduce their foot. So their foot is in valgus, and when you examine them, they're stuck in valgus. You can't kind of get their hind foot underneath their leg. And in these cases, the surgical option is a arthrodesis. So traditionally, it has been a triple arthrodesis, which is the talar navicular, the calcaneal cuboid, and the subtalar joint. But more and more, a lot of us are doing what we call double arthrodesis, which is the talar navicular joint and the subtalar joint. And we leave the calcaneal cuboid joint alone. And the reason, if you think about it, is if you have someone who has a valgus hind foot, when you reduce them, you actually distract, and kind of the calcaneocuboid joint will actually widen. So a distracted joint usually doesn't cause pain. So there's really no need to actually fuse this. So we really just fuse the talar navicular and the subtalar joint. And what's really important here, I haven't read, is that you want to reduce these, right? So it's not just kind of fuse them in situ, not that anybody would or should, but you really want to make an effort to reduce them, and not just halfway or partially reduce them. You really want to reduce them fully. And the reason is because if you under reduce them, you can imagine that now you have this huge fusion mass. Let's say they heal, and this is going to put a lot of torque on the ankle. And a lot of times patients who have kind of under reduced hindfoot after a double or triple arthrodesis will actually go on to actually have very progressive valgus arthritis of their ankle, because now you've sort of reduced it but didn't fully get it, and now their ankle is in valgus because it's putting so much stress on that deltoid. So it's really important to really reduce these. The problem with these triple or double arthrodesis is that once this is done, the patient has no side-to-side motion, and it's really hard to walk on uneven surfaces. And then also, I always tell patients, it'll help your pain, but the problem is when you have a double or a triple, you are going to normally put less or more stress on your ankle joint, and this is likely going to lead to some premature ankle arthritis in the future. Okay, I do not remember who went last. Someone remind me.
I went last. I'm actually not sure who hasn't gone at this point. I think pretty much everyone.
How about Aaron? Aaron has not gone.
Sure. Figures 1 through 3 reveal weight-bearing foot and ankle radiographs, respectively. A 65-year-old woman with history of obesity and chronic right foot pain with progressive flat foot deformity present for several years. Examination demonstrates a rigid planovalgus foot deformity with hindfoot valgus, forefoot abduction, and collapse of the medial longitudinal arch. Shows inversion weakness and inability to perform a single limb heel raise. Passive dorsiflexion of the ankle in subtalar neutral position is approximately 0. She has failed non-surgical management with orthotics and bracing. Surgical management of this condition would include medial displacement calcaneal osteotomy and FDL longus transfer, lateral column lengthening, calcaneal osteotomy. Are those separate things? Okay.
Right, yes,
One thing.
yes.
FDL transfer, gastroc recession, triple arthrodesis, gastroc recession, tibiotalo-calcaneal arthrodesis.
So this is the X-ray, but you can tell it's a pretty severe deformity, and they tell you it's rigid, right?
Yeah,
Rigid.
so it would be triple arthrodesis with gastroc recession.
Perfect. All right. Okay, so mid to long-term outcome of these patients who have really solid fusions are actually pretty good as long as you reduce them. So this is a study that basically they had a lot of patients, so 84 for a foot and ankle study, that's a lot of patients, and they followed them for 5 years, right? So maybe midterm. So they ended up having some non-union, some ankle arthritis, but these patients really did well, most of them. Out of 84 patients, they had better functional scores, they had less pain, and overall they're pretty happy. The other thing to keep in mind is that this study by Pell actually found that yes, we do know that these patients will develop some sort of arthritis after a double or triple. There's actually no association between their patient satisfaction. And again, these patients are really happy. I think part of it is, these patients waited so long, their foot is like stuck and it's painful. So they have the surgery, even though they're stiff, their pain is, mostly gone. So they're quite happy with the outcomes. Okay, so let's see. Aaron went. How about Brandon? I see Brandon. What?
Hi. Yeah. I'm a med student.
You're a med student. Okay.
I'll give it a try.
Okay, sorry.
So figures 1 and 2 are the clinical photographs. 55-year-old woman who had a right hindfoot fusion 3 years ago for pes planovalgus deformity. Since surgery, she has had lateral hindfoot pain and places most of the weight-bearing load on the lateral border of her foot when walking. What is the most likely cause of her symptoms? Okay.
Yeah, so I give you a hand, I'll help you here. So you can see here's, both feet, right? I can't tell which side was a surgery, but they did a pretty good job. They've got the reduction, so there's no residual valgus anymore. So this is what they're showing you is that, they're pushing, and that first ray is still really kind of dorsal, right? And then we know this patient had a fusion, right? So what do you think they did? They didn't place this in the right position. They really needed to kind of bring that down. So which one of these is most likely causing her symptoms?
It's not A. It's not, I don't think it's forefoot abduction. No, it's not it.
Correct.
Transfield valgus.
It's not a valgus, right? Because you can see they've reduced her very nicely.
Yeah, it's not that. Thinking E, malposition of the transverse tarsal joint.
You got it. Okay, perfect. Thank you, Brandon. So moving on to stage 4. So these are patients who now, not only do they have subtalar arthritis and it's stiff, you can't move them, they've waited so long that they now have ankle arthritis, right? So their ankle, you get an x-ray and they've got a valgus deformity there. So in stage 4, they kind of divide into, is the ankle valgus flexible or is the ankle valgus stiff? And if it's flexible, you can fix the deformity, and then technically you can do this deltoid ligament reconstruction. So what I would say is they probably will never test you guys on this because it's very controversial. The deltoid or spring ligament, all those reconstructions, they essentially have been shown that they don't work, and there's only like 1 or 2 people in the foot and ankle world that does them. And the other thing is, when you have a valgus ankle, your ankle is, that's arthritic already, right? Because it's in that position. So you can sort of not really think about this flat foot deformity with flexible ankles. So pretty much everything on your test will be a flat foot deformity, but with a stiff ankle. So it's this column that we want to focus on. So when patients have stiff flat foot deformity and a stiff ankle, what you want to do is you want to fix the foot. So you want to get the foot out of that valgus position, and you want to fix the ankle. So that can be done with an ankle replacement. And also, I would say probably the test answer when you see a stage 4 flat foot deformity is a pan-talar fusion, which is right here. The problem with the pan-talar fusion is when you do a pan-talar fusion, you fuse the ankle, you fuse the subtalar joint, you fuse the talar navicular joint, and you could potentially fuse the CC joint. So it's essentially, these patients have, nothing moves, it's stiff. You've essentially given them kind of like a peg leg to walk on. And so we really don't do a lot of pan-talar fusions in practice. I cannot remember ever doing a pan-talar fusion. What we generally try to do are these TTC fusions. So TTC fusions is not a pan-talar fusion, it's a fusion of the talar navicular or tibio-talar joint, which is the ankle, and then the subtalar joint. And we try to leave the talar navicular joint alone. So you do a TTC fusion, and then if you have any residual forefoot deformity, you can kind of bring that forefoot down with this plantar flexion osteotomy of the medial cuneiform. And then certainly don't forget about the Achilles or the gastroc. Oftentimes the deformity is so bad, you do have to end up doing a tendon Achilles lengthening. So this is just some cases. I personally have never done a deltoid ligament reconstruction. So Deland is one of the people that does it at HSS. So you can see this patient here, they clearly have a stage 4 deformity because they are ankles and valgus. And this is one of those flexible ankle valgus patients. So here he's corrected the hind foot. You can see all these things, right? So he actually didn't fuse any of the joints. All he fused was the first TMT. So he essentially did osteotomies, lateral column lengthenings, and got the foot out of valgus. And then he did this deltoid ligament reconstruction. And these screws here are kind of the posts that he kind of ties the allograft onto. And so this, looks great, but we know that long-term myoses do go on to failure. And so this is a patient who ended up going on to failure. So he ended up putting a total ankle in. So in summary, it's really important to remember that posterior tib tendon dysfunction is a deformity in 3 different planes. You want to relieve pain, correct alignment, and preserve motion as much as you can. When they get to fusions, sometimes the patients don't do well because they're just so stiff. And we really want to focus on early surgical interventions. So we want to try to get these patients and fix them while they're in stage 2. That way we can help save their joints and keep them more supple. And then I do tell these patients if we get to them in stage 2, they do quite well, mostly normal function, can do anything that they want. Okay, so let's do another question. Let's see, who's not, how about Nick? Is Nick on? Okay.
I haven't gone either. It's Erica.
Sorry, who's that?
Erica.
Oh, Erica. Okay. Can you do this question, Erica?
Sure.
Okay.
So a 57-year-old woman developed flat foot deformity 2 years ago. She has medial ankle pain and swelling. She also has posterior calf achiness with prolonged walking. What are the pathomechanics of her calf discomfort? 1 is increased external leg rotation. 2 is a more horizontal subtalar joint axis. 3 is plastic deformation of the plantar fascia. 4 is altered kinetics of the foot intrinsic muscles. And 5 is inability to lock the transverse tarsal joints. And I was going to go with 5, putting increased stress on the Achilles and gastrosoleus complex causing this calf achiness.
Right, that is correct.